Hi everyone, my name is Anna Davis and today I'll be presenting my evidence-based practice project on early mobilization following neurosurgery. Postoperative neurosurgical patients have traditionally been on strict bed rest because of concerns about neurological stability and surgical complications. However, a growing body of evidence shows that immobility actually contributes to worse patient outcomes, including respiratory issues, muscle loss, and longer hospital stays. Early mobilization, so within 24 to 48 hours, is emerging as a safe, effective strategy to accelerate recovery. This presentation will review the evidence related to early mobilization, outline the PICO question guiding the study, and describe the proposed plan for change using an organizational change method. Significance of the practice problem. Immobility increases the risk for muscle atrophy, thromboembolisms, pulmonary complications, delirium, and extended hospital stays and cost. Neurosurgical patients, who are often older adults, are particularly vulnerable due to the neurological deficits and limited mobility. The literature consistently shows structured early mobilization as a way to reduce preventable complications and enhance recovery. My question is, in postoperative neurosurgical patients, how does early mobilization compared to delayed mobilization or prolonged bed rest affect functional recovery, postoperative complications, and hospital length of stay from surgery to discharge? The population includes adults age 18 to 85 who have undergone cranial or spinal surgery. The intervention is structured early mobilization, which typically begins between 12 to 48 hours after surgery. The comparison is the traditional postoperative approach, where immobilization is delayed beyond 48 hours. This conservative practice was originally based on concerns for wound stability and neurological deterioration. The key outcomes evaluated include functional recovery, postoperative complications, and hospital length of stay. The timing in this question refers to the acute postoperative period until discharge. A comprehensive literature search was conducted in the databases listed using keywords such as early mobilization, neurosurgery, early ambulation, and postoperative recovery. The inclusion criteria were adult neurosurgical patients, English language publications, and peer-reviewed studies from 2020 to 2025. 20 articles were identified, and after removing duplicates and screening for quality and relevance, 10 articles met all inclusion criteria. The literature shows strong consistency in favor of early mobilization. Studies report earlier achievement of mobility milestones, fewer respiratory and thromboembolic complications, and shorter length of stay. Pinto and colleagues even found long-term functional benefits that persisted at 1 year post-op. The evidence also emphasizes the importance of interdisciplinary teamwork. When all teams collaborate, mobilization occurs earlier and more safely. Altogether, the evidence strongly supports the implementation of a standardized early mobility protocol. Setting for the planned change. The proposed practice change will take place in an acute care neurosurgical unit. This setting includes patients recovering from a variety of cranial and spinal procedures. Currently, mobilization practices on the unit are inconsistent. There is no standardized protocol guiding early mobilization. Because delayed mobility is a known risk factor for complications, implementing an evidence-based early mobilization protocol has the potential to significantly improve patient outcomes in this setting. To guide implementation, I will be using Cotter's 8-step process for leading change. This model is well suited for organizational level practice changes and offers a clear, systematic approach to transforming culture and sustaining improvements. The first step is to create a sense of urgency. I would share data showing current complication rates, delayed mobilization rates, and length of stay. I would highlight the evidence demonstrating that early mobilization reduces preventable harm and improves recovery. Next, I would establish a strong guiding coalition consisting of nurse champions, neurosurgeons, physical and occupational therapists, and quality improvement leaders. This interdisciplinary team will be responsible for developing the protocol, removing barriers, and educating the staff. Step 3 involves developing a clear vision and action plan. Our vision is to improve neurosurgical outcomes through safe and standardized early mobilization. The initiative includes developing an evidence-based protocol, creating safety screening tools, and implementing staff education and documentation processes. To ensure buy-in, the vision must be communicated consistently and frequently. This includes discussing the change in staff meetings, during shift huddles, and through posters and written materials. In Step 5, the goal is to empower the staff by equipping them with the knowledge and resources needed to perform early mobilization safely. To maintain momentum, Step 6 focuses on generating and celebrating the short-term wins. Recognizing staff contributions and highlighting patient success stories helps reinforce the value of this change. Step 7 focuses on sustaining progress by continually evaluating outcomes and addressing obstacles. This includes tracking data trends, ensuring ongoing staff education, and updating the protocol as needed. The final step is to fully integrate early mobilization into the organizational culture. This includes embedding the protocol into the electronic health records and incorporating interdisciplinary review into routine staff meetings. Once these practices become standard care, the change is fully institutionalized and sustained over time. To evaluate the effectiveness of the early mobilization protocol, I will measure these 4 key outcomes: functional recovery, complication rates, length of stay, and protocol adherence. These metrics will help determine whether the intervention is improving patient outcomes and whether additional modifications are needed. Data will be collected from the electronic health record, physical and occupational therapy documentation, and quality improvement reports. Weekly data collection will occur during the early implementation phase and monthly thereafter. Analyzing trends using run charts or dashboards will allow us to compare pre- and post-implementation outcomes. The results will be reviewed by the guiding coalition and shared with leadership to support transparency and continued improvement. The dissemination plan includes presenting the outcomes to neurosurgery, nursing leadership, and therapy staff. Information will also be shared through hospital quality improvement meetings. There is potential to develop a conference poster or podium presentation for American Association of Neuroscience Nurses, and the findings may also be suitable for publication in a nursing or quality improvement journal. In conclusion, early mobilization after neurosurgery significantly improves recovery and reduces complication rates. Evidence demonstrates strong support for adopting structured protocols. Using Cotter's change model helps ensure sustainable, effective implementation. With interdisciplinary collaboration and ongoing evaluation, early mobilization has the potential to significantly improve patient outcomes and enhance the quality of neurosurgical care. And these are my references.